Good morning, Colorado. It is such a joy to have you here with us today. Kelly, let's go to the next slide. So today is a
Buenos días,
really
Color.
important webinar to make sure that everybody can engage and that we are a Colorado for all. So American Sign Language is available, audio only is available, Spanish interpretation, which is Hans you heard talking there earlier, closed captioning is available. They can all be accessed via the toolbar in Zoom down at the bottom of the screen. Registrants, we have about 1,300 of you today. Again, thank you for being here. Questions for the speakers can be put into the Q&A feature. We have three ways we're going to answer those questions. There's a panel in the middle. There's a panel towards the end, and those panels are CEOs of the hospitals. And then we'll open it up towards the end of the session for another round of Q&A to all the speakers. Materials are posted there as seen on the screen. And we will send everything out after, and we'll post the materials as well. That's the slides and the recording in Spanish and in English. One of the most important things that we capture from this webinar is your perspectives through the polls. Please take the time to engage in those polls. There's so much going on, and we really need to know your aggregate views. Thanks so much for that. Let's go to the next slide, Kelly. So today's agenda. We're going to introduce the speakers. We're going to hear, and I'm going to ask you to just get through with us about 20 slides of facts. Then we're going to have 30 minutes for panel discussion with our hospital CEOs. Then we're going to have more insights on specific areas that are also keenly of interest to you, from community benefit, Chase reports, and HR1, the Rural Health Transportation Program update. Really exciting second panel, and that'll be more towards the end of the webinar. Let's go to the next slide. Kelly. Next slide there, Kelly. So we have internal speakers. They will introduce themselves when they start. You can see who they are on the screen, but a mixture of HCPF leaders and absolute experts, and they're all subject matter experts, and we're looking forward to hearing from them. That's the material that you'll hear when I'm saying the facts and learning from the 3 reports that we produced that are fueling the data and the information shared in this webinar. Let's go to the next slide. And we also are delighted to have with us spectacular hospital CEOs, all in their own right. So we have Donna Lynn, Dr. Donna Lynn, who is the CEO of Denver Health with a spectacular background, really done a great job of turnaround Denver Health. Still on a journey, but wow, what a great system we have as a safety net here in Colorado. Dr. Rob Vissers, representing independent. We have so few independent hospitals. They're rural, and then just a few larger than rural systems. And Dr. Rob Visser is also a emergency room doc, so CEO of Boulder Community Health. Margot Karsten is the incoming board chair of the Colorado Hospital Association and CEO of Banner Health, also a spectacular thinker and collaborator. And Kevin Stansberry, CEO of Lincoln Community Hospital and representing our rural hospitals. And there's so much going on nationally due to HR1. We really need to hear the perspectives of our rural hospitals as well. So we're so delighted to have, again, this CEO perspective shared 2 times during this webinar. Let's go to the next slide, please. So why do we do these webinars? Boy, there's a host of reasons. One, the focus today on hospitals is because hospitals are the biggest part of the premium dollar. They're the biggest part of the healthcare sector. So it's hard to move the needle in any aspect of healthcare without having active engagement from our hospitals. And so that's one really good reason. Second, boy, from an affordability perspective, we always need the hospital's engagement. From quality perspectives, we need the hospital engagements. And to drive meaningful results, we need the hospital's engagements. It also is a really great way to engage with hospitals when we have times of dynamic change. What it seems like we just have one time of dynamic change after another. We're in one now, and so this is really important. One of the takeaways that I would invite everybody to hear from this webinar and feel from this webinar is we are going to get through this times coming before us, which is going to be a very difficult landscape because we work together, because we recognize where we are now, the challenges before us, what the goals are that we have shared, and how we get there together. And so these panels are to help us make sure we're communicating well, we're hearing from each other, and we need to keep doing that going forward. So I want to start with a big thank you and a call out to the hospitals, because one of the issues that has been a tremendous success story is we have illuminated where we started in 2018 when we started transparency reporting. And you can see over to the left where we're highest in the nation in total profits, fifth highest in prices, and the hospitals have worked very hard to course correct to the betterment of consumers, patients, employers, taxpayers. And the first thing we have to do is say, thank you. This is self-correction, and it's outstanding. When you measure the value of these self-corrections when it comes to price and what we're all paying, $3.7 billion. As we've moved all these metrics are moving what I'll call the right direction. I want to go to the next slide, and I want to clarify, because Connie Martin reached out to me after the last webinar and said, Kim, the right direction isn't always the right way to categorize this, because rural hospitals, when profits are going the wrong way and prices are moving, maybe we have not so good outcomes. So I want to thank you, Connie, for making sure, man, we are collaborating and we're hearing each other. I heard you. And so I want to call out rurals. This is a rural hospital comparison. And so you'll see, again, things moving in a direction maybe to the benefit of consumers and taxpayers and employers. But when you look at the difference between how prices are moving from fourth to sixth, so sixth to ninth, a little bit of relief for employers and patients and consumers. But look at the profits. They are moving in a very different range. And that's a call out to what Connie's saying. Whoa, got to be careful there. So if we look at some of the highlights here, you met one rural hospital, many are struggling here in Colorado nationally. Haven't lost one yet. Haven't had one go under, and we're all working together to make sure that's a record that we continue. Many mountain resorts are very different financial experience. And you'll see some of the higher prices, but not necessarily those higher profits. Part of that is due to expenses, 22%, 22.7% total expenses. In rural, as a percent, or admin represents 22.7% of total expenses, but compared to urban, it's only 13.6. So we've got an opportunity. We've got to help our rural hospitals do all the things they need to do to drive that quality and access. But how can we help them to do that in a more efficient way and to protect their sustainability as we move forward? Let's go to the next slide, please. Another reason we do these webinars is just see big picture. Hospitals are the biggest part of the premium dollars, we said, but that's for Medicare, commercial, and Medicaid. To the right shows Medicaid. Then the last bar down at the bottom, hospitals without the supplemental payments of an additional $1.7 billion, about 20% of our costs. I want to call out and compliment that our costs for caring for those with disabilities under long-term services and supports are moving at a higher rate of cost trends than our hospitals. I want to say thank you for the work to control those cost trends, because that number, 20%, used to be more around the 28% range. So that's a healthy space for overall Medicaid and for our system as general, but we want to complement our hospitals with having a different number there than it was before. We also want to recognize that that's coming down because of the unusual and outlier trends associated with about 45% of our claims. Again, those are for long-term services and supports. Let's go to the next slide, please. Why else do we do these webinars? To show some of the really interesting points, which will be on these next 3 slides. On this slide, you'll see total net patient revenue, which is the blue line that is the representation of just that revenue. Now, it doesn't include things like investment earnings. It's just straight patient revenue representing Medicare, Medicaid, commercial, self-pay. And then the yellow is the expense line. And you'll see the expense line starts to cross over, not good, the revenue side. You'll also see a nearly doubling from 2014 over the decade plus period to 2024, from about 11 to 12 billion for all of Medicare, Medicaid, commercial, et cetera, to 24 billion. And that's why we say, boy, there's at the other side, our taxpayers, or the other side of paying all of this, are consumers and employers. So we've got to recognize the sustainability of that. How do we work together to get it down, but also recognize where the hospitals are struggling? Again, that expenses going above that revenue line. Let's go to the next slide, please. It's also really important to recognize the significant increase in labor costs. 45% of operating expenses are for labor expenses. That is tremendous. And if you look at the payroll increases, that third bullet, 46% increase between 2020 and 2024. That yellow bar all the way down the bottom, that represents the staffing agencies that were predatory during COVID, a really difficult circumstance for all parts of healthcare, from nursing homes to hospitals, the entirety of the system, our clinics and our doctors' offices. But we need to recognize that we have a higher bar now for labor expenses, both benefits that you can see, total payroll expenses all at that top bar. And you can see down at the bottom, increase in workforce is part of that, 36% increase in hours as well. Let's go to the next slide, please. I want to call out another really big important part. Green bars up the top represent Medicare, yellow is Medicaid, commercial is in blue. Massive difference. If we've seen from 2014 to 2024, Medicare is increasing significantly. Remember, we're in the fastest growing states for seniors or older adults over 65. And that's represented by an enormous increase of 14% of monies. And Medicare is always the highest payer for our hospitals, not including Children's Hospital or Rocky Mountains Children's Hospital inside HCA or Presby St. Luke's. But outside of that, they're the biggest. From a payer mix perspective, Medicare is the biggest. But when you see that happen and Medicare is not paying enough or a higher level of costs, that can be problematic when you see that 41% and Medicaid right below it is sitting about the same, 19%. We get a little higher through COVID, et cetera, coming back down to about that 19%. Now, we cover about 22% of the population, but from a hospital payer mix perspective, still staying at pretty much flat. Now, look at the commercial side, the blue bars. This is concerning as well. Traditionally, the commercial side, private insurance, pays higher than hospital costs. It gives them the buffer. But look at when that commercial side goes from 36% to 29.7%. Holy wow, we've got a drop down 18% from commercial. Why do we do these webinars? Let's see the big picture. Let's solve big problems together and have good dialogue. I'm going to turn it over now to Austin. Let's go to the next slide, Kelly. And we're going to start to jump into the weeds a little bit more. You'll see us dive into rurals, dive into various metrics of profit. And again, you've got about 20 slides all in the aggregate before we get to our first panel. Austin, over to you.
Thank you, Kim. Hello, everyone. My name is Austin Wozniak. I'm the new Acting Deputy Division Director of the Special Financing Division here at HCPF. I've been with the department nearly 6 years now, producing and then leading much of our hospital financial and economic reporting. I'm happy to be speaking with you about some of that information here today. Those factors of cost and payer mix shifts that Kim was talking about all relate with measurements of payment to cost for each payer shown here. You can think of these ratios in this table as representing how much payment occurs for each dollar of cost. And in that framework, it is good to remember that both payments and costs are flexible things that change over time. As Kim just mentioned, Medicare's payer mix has been growing, and we see here in the leftmost column that payer mix trend is joined by a falling payment to cost ratio over time, which indicates a growing under reimbursement from Medicare. Although national studies do show that Medicare payment rates should closely match reasonable costs for hospitals. We also see the Medicaid payment to cost ratio has stayed similar since 2020 and increased from earlier periods. Commercial payer mix and payment to cost have both increased slightly between 2023 and 2024. On the furthest right column, overall, we see that in the last 2 years, hospitals across the state have come in at payments meeting costs for patient care at 1.0 flat. Next slide, please, Kelly. This table looks at various hospital profit measures. Patient service profits, the first measure on the chart, reflects profits generated from patient care, which have been minimal over the previous 2 years. Operating profits, the second row on the chart, include patient service profits plus other operating activities like the hospital's medical education tuition, gift shops, cafeterias, and parking lots. Total profits, the bottom line on the chart, add investment gains as well as non-operating activities like grants, federal stimulus, and tax subsidies. There have been a lot of swings and shifts throughout these recent years, driven by growth in operating expenses, inflation, stimulus funding, and of course, pricing decisions from our hospitals. Patient service and operating margins have increased from 2023 to 2024. But what we hope you take away from this different perspective of hospital profits is that we can't just look at patient services. Investment earnings are a large portion of Colorado hospital earnings, roughly 50%. However, large declines from the market, like those in 2022, are possible as well. It is important to note that not every hospital is sitting on significant reserves or profits, and we're going to dive deeper into those breakdowns here shortly. Next slide, please, Kelly. While the statewide aggregate amounts are useful to see broad trends, it is important to remember that there is lots of variation within the state's hospitals. Shown here is a new breakdown that looks deeper into the statewide payment to cost ratios, and while overall for the state, Medicaid pays 80 cents on the dollar for cost, over 40% of hospitals saw Medicaid pay above costs in 2024. From 2020 to 2024, the share of hospitals being paid above cost for Health First Colorado increased from 29.6% to 42.9%, while the proportion of private insurers paying above cost decreased slightly from 85.2% of hospitals to 81.2% of hospitals. Increases in Health First Colorado cost coverage are largely driven by reforms in hospital provider fee payment methodology, resulting in an increased reimbursement to providers. Next slide, please. Breaking down those proportions of payment to cost even more into different categories, we can see some noteworthy differences between rural and urban areas. Between 2020 to 2024, rural providers have consistently represented the largest share of hospitals fully reimbursed by Medicaid, with nearly 70% of rural hospitals being paid above cost by Medicaid in 2024. Over the same period, over 95% of urban hospitals had their costs fully covered by private insurance, while the share of rural hospitals with full coverage from private insurance is now only 66.7% in 2024. For rural hospitals, that's a lower portion of hospitals being paid above cost for private insurance than from Medicaid. These trends may be due to differences in pricing power and privately insured patient volumes, allowing the vast majority of urban providers to achieve full coverage. Costs are another important factor in these measures, and many hospitals have cost efficiency opportunities, as we saw with our nationally high-ranking costs. Next slide, please. For the next few slides, we're going to go back to looking at total profitability, including investments for hospitals. Here we are starting with our systems. This includes national data for systems with providers outside of the state. System hospitals maintain pre-COVID total profit margins, and continued stabilization has occurred after the 2022 investment market downturn, which primarily affected hospitals who utilize investment markets. All major systems operating in Colorado are trending towards higher total profit margins in 2025, with some having margins above 10 or even 15%. Next slide, please. Dropping down to the hospital-specific level of profits, we can take a closer look at hospitals in the state to see if we identify any trends or groupings. While many major systems had strong profits over the last couple of years, there are many hospitals in the state with a negative total margin or a loss in 2024. 22 hospitals, or 26%, had these losses in 2024. Trends with total losses for urban hospitals include high-pressure markets like Northern Colorado and newer hospitals that are getting a foothold in the marketplace. Also, developing markets where hospitals are building for the future and future population growth. Next slide, please. The same information in the previous table is shown here with all of our other hospitals. I know you might not have gotten a chance to read every hospital name on the last slide. Each bar represents a category of profits from less than negative 4% up to a greater than 10% margin. The colors represent urban hospitals in blue, rural in gold, and critical access hospitals in green. HCPF reporting helps identify successful versus strained hospitals through a wide range of hospital financial success. Some hospitals' total profit margin, which includes investments again, is as low as negative 25%, all the way up to 32%. As we saw on the last slide, 22 hospitals, 26% of hospitals in the state had losses. This is a decrease of 10 hospitals from 2023, which we're happy to see. We saw the individual hospital names on the previous slide. Interestingly, all 15 urban hospitals with losses were part of large systems. We saw a couple slides ago that those systems made profits overall. Many system hospitals record their investment gains at the system level at their home bases, and therefore are not shown in total profit margins at the hospital level like other hospitals that do record investments at that level of leadership. Now back to you, Kim.
Austin. So I want to talk a little bit more about our rural hospitals. So our rural hospitals, some characteristics that are pretty common. A higher payer mix of patients in public programs, Medicare and Medicaid. Higher and compensated care. Far fewer inpatient beds and stays, and they depend on outpatient clinic services, the rural health clinics. There isn't a large system to rely on for administrative costs. They have a lower days cash on hand and reserves, meaning they're driving lower investment incomes, while they also have that larger space when things go wrong to dip into rainy day reserves. They have higher admin as a standard, 22.7% of total expenses for rural, and compared to 13.6% for our urban hospitals. They have lower margins and profits as a standard. Again, the exception is those mountain town resorts. And often they depend on community taxes. Let's go to the next slide, please. So this state invests in rural hospitals, does the best we can, and that's one of the reasons as we work in partnership that we haven't lost any of our rural hospitals. And so we've also built in certain support services, like, for example, in the last RAY bid, we required the RAYs who are covering rural areas to provide for free infrastructure that allows the rural hospitals and their clinics to build ACO-like infrastructure. That is really important to control cost and drive better outcomes for patients in the rural communities. And we did that together. We also, through the Office of eHealth Information, which is a spectacular resource here in Colorado, we've also built tools for our hospitals, rural hospitals specifically, that they can build those systems, leaning on those tools to also act like an ACO. We have the Rural Transformation Support Fund, 60 million over 5 years, about 12 million a year for certain hospitals. We've already paid out about 48 million. I'll go down a few just for time's sake. Lots of support for connectivity, grants for affordability and access that we put forward through COVID and those times. And I want to call out Kevin Stansberry for helping build legislation and policy in collaboration with healthcare policy and financing that allows hospitals to work together in order to have economies of scale to pull down those to improve those hospital efficiencies and admin efficiencies and get better results. Really a great bill, and that bill was expanded in 2025 to add the Alamosa region, so it's not just an independent hospital, but rural hospitals that might already be joined with several hospitals under one roof. Let's go to the next, I should say under one ownership. So where we still have opportunities, can rural hospitals consider new licensure? So we have many rural hospitals only have 3 patients or so average staying overnight inpatient on average. It's hard to cover all your administration when you're that small. So we might want to look at different licensure, like an emergency licensure, which allows a little more flexibility. We want to take advantage more of these 2 bills that I just referenced in order to share expenses and figure out how we can drive those better economies of scale, but also partnership where they can share the ability, everything from doing things like sharing how do we buy supplies, how do we buy drugs together, how do we better recruit and train our workforce. There's so many things that we can do that help bring to our rural hospitals the efficiencies and gains that are similar to our systems. Won't be as great, but we sure do have a lot of opportunity there. From an affordability perspective, we also have some of the highest prices in the nation in our rural communities. So how do we help our rural hospitals improve their ACO-like accountable care organization, like primary care management structure? We already said we've got those free tools. Let's make sure everybody's using them, all the rural hospitals. How do we then share the hiring of nurses so that they can manage care more effectively through their rural clinics? How do we help them have shared resources so they can manage better the utilization management challenges that we have in the insurance industry, the payer industry, whether it's HCPF or Medicare or Medicaid? How can they share clinicians that help manage that, whether it's RAC on our side or prior auths? How can we help them with that? Next, we got to do a lot more with Chase. We'll talk about that in part 2 after the panel. And how do we collaborate to bring down more federal dollars and navigate this very difficult federal landscape that we're going into? Next slide, please. And I'll turn it back over to Austin.
Thank you again, Kim. I'm going to briefly cover hospital reserves as we move forward. Days cash on hand, or reserves, measure financial stability and an opportunity for investment income for hospitals. The S&P provides information on various financial measures and what are considered strong and weak positions for them. For days cash on hand, S&P indicates that around 150 days places a hospital in a strong position. We see here on the right that there's a wide variation between hospitals in 2024, from just 13 days cash on hand to over 348 days, with rural hospitals having the lowest days cash on hand and a median of 143 compared to urban and system hospitals having a median of 220. That's over 2 months of additional liquidity. Overall, days cash on hand medians have returned to values before the COVID-19 pandemic, where days cash on hand was buoyed by federal stimulus dollars to hospital during that period. Next slide, please. So far, you've heard about how Colorado hospitals are trending in the right direction nationally and how there's variation across individual hospitals. Here, we combine those two concepts to review individual hospitals that may be price or cost outliers compared to similar peer groups across the nation, driving Colorado prices up overall. The scatter plot on the right displays the percent above the peer group median for price, where 100% equals the peer group median versus the price savings if that hospital had prices at the median value for its peer group. Peer groups are based on bed size, Medicare case mix index, teaching intensity, and service intensity to come up with the most similar hospitals across the country for these peer groups. If these outlier hospitals, were more similar to their peers across the nation, approximately $1 billion of potential savings could be seen across all payers in Colorado. The department plans to meet with these outlier hospitals in the coming months to discuss and work towards lower prices for patients. Next slide, please. Speaking of prices, HCPF is also working to transform the economics of the health system with tools on prices, payments, break-even rates, and financials. Prices are the most important variable to Coloradans, employers, and taxpayers because hospital prices are what factor straight into insurance premium prices. HCPF's free price comparison tool allows users, like employers and their associations, legislators, policymakers, insurance carriers, advocates, communities, and others to compare commercial prices by hospital, by insurance network plan across more than 5,000 different procedures. It also helps inform productive conversations between communities or employers with hospitals about their prices. This visual from the tool looks at MRI scans. You can see the wide price variation amongst plans in the Denver metro area. You can leverage this tool to see if your local hospitals are charging higher or more competitive prices than other Colorado hospitals for the same services. You can look up births, cardiac and oncology procedures, colonoscopies, and so much more. Pricing information is also working its way into insurance carrier websites when you look for care on your private insurance plan. This allows you to choose options with smaller deductible payments for your own specific insurance plan. The pricing data in this hospital tool is updated twice a year, with an update coming in the following weeks. If you'd like a demo or help comparing the prices for hospitals in your employer region or your community, you can reach out to my team for support at HCPF_hospital pricing at state.co.us. That email address is also at the bottom of this slide. And now we'll hand it off to Dr. Lisa Rothgary.
Thank you, Austin. Hi, everyone. I'm Dr. Lisa Rothgary, our Chief Medical Officer here at HCPF, and I'm going to share a little bit about physician acquisitions with you today. The latest legislation on hospital transparency requires the sharing of physician acquisitions by hospitals. These physician acquisitions are a type of vertical integration, which is the consolidation of different successive stages of healthcare delivery under one corporate umbrella. In early 2024, 55% of US physicians were employed by a hospital or health system. That's over half of all physicians nationally. In Colorado, you can see on this graphic, over the last 10 years, 79 physician practices have been acquired by a hospital or health system. Approximately a third were acquired by UC Health, another third by independent hospitals throughout the state, and 17% by Common Spirit. There are lots of reasons for vertical integration. We often hear that the goal is to streamline the continuum of care or to secure patient access to providers through hospital purchase of struggling independent practices. However, regardless of the intention behind the acquisition, studies repeatedly show that vertical integration leads to higher prices. This continues to be an area of opportunity, so we all need to work together to evaluate how best to stabilize access to care and drive high quality care while avoiding the cost increases that can come along with vertical integration. Next slide, please. We also must share the salary and total compensation for the top 5 highest paid administrative positions for each nonprofit hospital. And you can see on this slide that in 2024, 1.4% of total payroll was paid to the top 5 administrative positions in aggregate. The average compensations for the top 5 positions for both large and medium hospitals was $355,000, whereas small hospitals were less at $182,000. System level admin isn't included in these positions. So for example, regional executives aren't included in these numbers. It's important to dive a bit deeper though, and really look not just at what the top hospital executives were paid, but at what they were paid to do. So at the bottom of this slide, you can see that the performance metrics in 2024 for CEOs prioritized quality of care outcomes, profit, margins, and patient satisfaction. And you can see at the bottom of this list that affordability was prioritized by only 41% of all hospitals. As we move ahead through these very difficult budget reductions and escalating healthcare costs, it's clear that affordability will have to be more highly prioritized than in the past, and we'll need to see hospital boards engaging administrators in meeting affordability goals. And then next up, I'll hand this back to you, Kim, to lead our first panel discussion.
Awesome. Thank you, Dr. Lisa. Panelists, if you could turn your cameras on. Dr. Lisa, if you could stay on as well, that would be quite lovely. And we're going to ask the questions of the CEOs, give them time to share their thoughts. And Dr. Lisa would like you to invite in wherever you want to share. I don't want this just to be me representing HCPF. So thank you for our panelists here. So the first question, and I would also invite you at the end to share whatever thoughts you would like to on the previous material. You're welcome to do that. And I want to thank Donna Lynn for joining from the Olympics in Italy. Donna, what time is it over there?
It's 4 o'clock and I didn't win a gold medal.
But I heard you got in a run of skiing already?
Yes.
Good for you. Send some of the snow over here. We need it. Okay. So to our amazing panelists, first thing, taking HR1 off of the table, what keeps you up at night? You are a CEO of the hospital. You are juggling every day challenges. What keeps you up at night? What solutions are you pursuing to address those concerns? And what do you need from stakeholders in the states to help you? So why don't we start with Margot? Throw you up first.
Thanks, Kim. For me, what I'm really challenged by and keeps me up at night, when I look at our payer mix percent, so our makeup, it's interesting in Northern Colorado, almost reflects identical to the stats you showed on the rules. So I have 2 rural facilities and then Northern Colorado that I support. And anytime I see a facility higher than a 70% payer mix that's government and underserved, I am really trying to be creative on how to get that cost structure down, because as you shared slides, government payers will not cover our costs. So I'm really trying hard with our team to be innovative on trying to build a sustainable clinical model of care that takes care of the underserved, knowing that we're being confronted with changes at the state and federal level, which we'll get to in the second part of the meeting. And innovatively, what we've done is we took a deep dive into the demographics and relicensed a facility. We realized we were in a community that was overbedded, closed down a freestanding ED to really try to make clinical care model efficient and effective in the communities we're serving. And we're going to continue to look at that type of strategy to stay sustainable.
Spectacular. Thank you, Margot. Thank you for your leadership coming in as board chair for the Colorado Hospital Association. Rob, you've also held that position, and Kevin, you have too. And so why don't we go next to Dr. Rob Vissers from Boulder Community Health.
Thank you, Kim. I think the thing that concerns me the most is the trajectory that we're on, and we're going to fall backwards in terms of our ability to serve the needs and the health of Coloradans. And I know it's much broader, and I know we're going to talk more about the legislation, but I just see the legislation as an accelerant of a pattern that you've demonstrated so clearly in the slides. Over the last 10, 20, 30 years, every year, I believe our care gets better in Colorado. Our safety is improved. The outcomes are better. And regardless how you measure it, some ways you could argue the direction we're going is wrong if we don't have as much margin. I use the word margin. We're a nonprofit. We don't make profit. To invest in our community. When you start seeing the expenses and that line go above below the revenue, regardless of whether you call it margin or profit or whatever, that's not sustainable. And we're going to start seeing some compromises in the care that we provide. Every individual on this call is committed to providing high quality access to every person in their community, regardless of ability to pay, Medicaid, Medicare, insurance, uninsured. We're hitting a tipping point where I don't see how we're going to be able to create that access and invest in the future health and wellness and improvements that we've been able to over the last 10 years, and face some of the significant challenges that we have coming forward, that trajectory that frankly is just being accelerated. So how we respond to that, how do we meet our mission, and continue to improve every year in the face of that is what keeps me up at night.
That's a lot. And it's something for all of us to really think through. Thank you for sharing your thoughts on that. And audience, I love this panel. These are really good thinkers, really good thinkers. Kevin Stansberry, what keeps you up at night?
Hi, Kim. Thanks for the chance to speak to the group today. Really just a big ditto on what both Margot and Dr. Visser said. My hospital serves an area roughly the size of the state of Connecticut, but I only have about 2 people per square mile in that space. So we worry a lot about making sure that our patients have access to the essential services that they require, and to do that in a sustainable way. You all talked about cash reserves. So for example, today, as I check our cash, we're at 40 days cash on hand. That's okay for us, but it is not at all sustainable. And at the same time, we are operating at a loss every year. And so we are slowly eating away at our reserves. And so in many ways, as Rob was talking, I was kind of thinking we're that future. We're already out in front of the tip of the spear because of our size, because of the age of our facilities. And so what I worry most is how do we garner the resources necessary to continue to offer that access to care? Because if we don't, there is no one out here. And Kim, you and I have talked about this before, and I say it to any policymaker, whoever I speak to, if you drive east on I-70, you care about my hospital. If you drive up into the mountains, you care about rural hospitals, because we're the ones that are going to be there to provide care. Last part I would make, and I really want to highlight on the commercial payments, we're roughly 75% governmental payers and another 5% self-pay. So I only have about 20% commercial, but in the aggregate, those commercial payers are my worst payers. I get paid less on average from my commercial payers than I do from Medicaid or Medicare, and that's just a bad recipe. And so we have to figure out a way how to balance the market power between small independent hospitals like mine and the large payers, how we can bring about equity to that and still respect the affordability for our patients.
Thank you, Kevin. I really appreciate your perspectives on representing rural hospitals. Dr. Donna Lynn.
Great. Thanks,
representing
Kim.
our safety net.
Thanks to you and all your team for all the work that you do. There's a consistent theme around public funding that I guess I want to echo. And I was struck by your slide of what the hospitals look like from a payer mix perspective. We're actually quite different because 50% of our patients are Medicaid. We've not seen the growth in Medicare, and 15% uninsured. So that leaves even less than Kevin in terms of our commercial payer mix, which is about 16%. And we're in a similar situation to Lincoln Hospital. The payers don't pay a lot of attention to either the rurals or the safety nets. And so our reimbursement is not as great as it is with other systems where they balance, the underpayment that you might get from Medicare and Medicaid with a higher commercial rate. So I think that overall dependence on public funding, as we've seen the overall commercial market share in aggregate drop down. I think your number was 29%. So for us, it's a lot lower. And for the whole market, I think we have to be concerned. The other thing, which I think Rob touched on, and we've never had this conversation, and I think we should, but access to care is actually a real challenge. We have no problem. We don't have empty beds, and we don't have short appointment wait times. And so the public is really demanding care. And I think that's true across many systems. The public wants to get health care, and sometimes they have to wait. And I think we as a state, to your question, what could we as a state do, is maybe shift the conversation around, do we have the right number of providers in the right places? And how do we provide good access to the people who live in Colorado?
Love that, Donna. Thanks for sharing. And I think the Rural Health Transformation Program is a little bit, you're leading us towards that conversation. So second question, the relationship between CEOs, leadership team, and the board of directors of hospitals is so important. It drives who you are and what you do and how you focus. So Rob, you've had a really interesting and fruitful relationship with the board. Can you share a little bit with us? How do you engage with your board to ensure you're meeting the needs of the community? And just how's your interaction? How's your priority decisions, et cetera?
Well, most of the healthcare provided in Colorado is provided by nonprofit health systems, and nonprofit health systems all have some form of board. Some of them are elected, some of them are appointed. I feel fortunate that our board is made up of community members appointed by the community and self-appointed. And so I have 15 amazing bosses that all are representative of really our entire community. And they take very seriously their role, which is not just the fiduciary success of our hospital to make sure that we can go on for another 100 years and serve the community and take our margin and invest it appropriately. But we've really shifted over the last, 5 or 10 years to focusing on quality and safety, access, like we talked about. Are we meeting all the needs of the community? All of us do a community needs assessment, and we spend a lot of time on that, take it very seriously. And in fact, it's the primary driver of our strategic plan. And it was really because of that, the voice of the community, that pushed us to make a significant investment in behavioral health a number of years ago. We just finished doing it again. Our community is the most rapidly aging community in Colorado, along with the whole U.S. And they said, we need more geriatric care, palliative care, end-of-life care, healthy aging, investing in that. And so that's our primary focus in our strategic plan coming forward. How we balance that with some of the economic challenges, well, that's my job. But having a board that's highly engaged, educated, and focused on the right things, and comes from and knows your community, tremendously valuable.
Spectacular. Thank you, sir. Thank you for your leadership in that regard. Kevin, I'm going to move over to you. We're going to talk a little bit about reserve. So as a rural hospital, you have worked hard to protect, build, figure it out, navigate. Share with us, please, what you have done, where you are in the journey, and what is next to tackle.
Thank you, Kim. First of all, I'll button on to Dr. Visser's comments. It starts with having a strong board and a board that understands the mission of the hospital and what we're trying to accomplish. We're very, as most rural hospitals are, we're very community oriented. We have community members that serve on our board. I don't have to call somebody else for permission to do things. Our board makes those decisions. And so it really starts with the board and their leadership. We have been actively pursuing management of the entire organization to try to streamline things. For example, our operating expenses have been flat and declining over the last couple of years because of just our need to make sure we're operating as efficiently as we possibly can. We're also very much adopted an abundance mindset and looking for reasonable services that make sense for our community to offer. So, for example, we do chemotherapy now in partnership with some of our system partners in the city who help us manage the drugs. But that way, patients don't have to travel into the city for care. God bless anybody that's had a loved one deal with cancer. You know, the story is always the worst part of the treatment is the drive home after chemotherapy. Imagine having to drive an hour and a half or 2 hours to get home. So by offering that service locally, it meets the needs of the community, and we can make a small margin back to Rob's point in order to invest in the future. We're going to continue to look at other services, but fundamentally, what we do is primary care, preventive care, and chronic disease management. And the better we can do that, then the better we can continue to maintain our ability to sustain ourselves. Unfortunately, that's a service line that doesn't reimburse a lot. And so we're continuing to try to advocate for ways to make those services more profitable, if you will, while still making sure that we're serving the community.
Excellent. Thank you, Kevin. I'm going to move us along to affordability. I'm going to go back to Margot here. So healthcare affordability is top of mind for consumers and employers and taxpayers. In what areas are you focused on affordability to the betterment of those critical stakeholders now, and maybe what are you looking to do in the future?
Yeah, Kim, I'm really proud of our primary care clinics. They have really worked hard on extended hours, open access, quick availability to first and third available appointments. And I think a year ago, we were ranked the highest in Colorado on the ACO measures. So we take it really serious on trying to keep whatever panel of patients we have healthy to avoid the admissions to the ED. So if you look at our makeup, you'd see extended clinic hours, urgent care, and like I said, closed a freestanding ED, closed another ED because we were oversaturated in our market. In the rural space, we really had to pay attention to Brush. Linda Thorpe is our CEO at East Morgan. FQHC had closed. And so what we're doing is making sure the vulnerable patients have appropriate care. And what that looks like is we got to put an OB in with our FPOBs because of high risk. So we can keep as many patients delivering in Brush as we can. And then we try to make it really easy for them to transfer as needed. But really looking at access is what we've focused on, and then worked with a couple of employers in Northern Colorado on screening availability, making it easy so that they don't need to come in and they didn't have their mammo and now they have a huge cancer diagnosis to treat. It's very hard. Banner is a small footprint, so I think we're 4% of the Colorado market. And very similar to what Kevin and Donna said, the payers, we'd be happy to take risk for quality outcomes, but because we're so small, we don't have great rates. So I think that's a partnership that we could think about is going forward. How can we make sure the efficiencies we're seeing and the health we're creating in our panels translates to a lower premium for our patients?
Really love that, Margot, and the focus of keeping people on that ACO side to have the best results in the state. That means your primary care is doing the right things and you're avoiding that ER. It's just exactly what we need to do as a whole system. And I love what you said. It's why we're working so hard to get the tools for ACO-like behavior inside the rurals, because that's exactly what we need. Spectacular. Thank you for sharing that. Donna Lynn, can you share your same thoughts on affordability?
Absolutely. And I want to just put an exclamation point on what Rob said about profit versus margin. We all have to make a margin, and the margin's essential because the technology keeps changing. We have to reinvest. We're replacing 2 MRIs over the course of this year. And we've made a lot of other investments that are necessary. And so when you see that 94 days of cash on hand, I want to tell you, you'll be happy to know it's actually 110 now. So we're feeling good, but not in the same range as many of the other hospitals that can take a risk and invest some of their reserves in whether it's building new buildings or adding new technology. On the affordability side, Margot talked about primary care, and we actually, as a system, I often say to people, Denver Health is not a hospital. We happen to have a hospital, but we're such a big system with 29 federally qualified health centers, which is where we want people to get care. We also, so from a preventive point of view, we can keep out of the hospital, as I think that's a theme you're going to hear all of us talking about. The other is that we provide we have 4 mobile health units. So we take care to the places where people who might, even within an urban area, find that it's geographically challenging for them, whether it's to take off work, it's to take 2 buses, it's to deal with other issues. So mobile health helps people in the community. And then we're in 19 Denver public schools, which I think is a really cool program, and taking care of over 16,000 young people a year. They're people who are dealing with mental health issues, dealing with reproductive health issues. And if we can get them into the health system as students, hopefully they continue to use the health system from a preventive point of view. And I think that all speaks to the affordability issue. We don't want people in the ED, although we take care of over 100,000 of them a year, but we really want them to be healthy and avoid accidents and illness where they can. So having that integrated system that we have at Denver Health really allows us to keep the cost of care down.
I really appreciate that, Donna. Can you just, one of the interesting things about your setup is you are a managed care organization, you are a little insurance company, and you are a hospital system, and you have all of the primary care basics, and you've invested in behavioral health. And so when you are moving the needle on affordability and you are doing all those things right, you can move it into a price without an intermediary, in essence, right? And that shows up as at a favorable basis on the marketplace exchange for individual, for Medicaid, for
Absolutely.
others. Can you just talk a little bit more about
Sure.
that, how that might change some of your behavior and how that might be an interesting model?
Well, and I noticed your slide, several slides back. I think it was Austin going through the cost of an MRI, and an MRI is an MRI. I mean, there's no complexity. There's complexity to reading it and interpreting it, but an MRI is an MRI. So we've been able to keep the cost of that down. I do worry a little bit. We haven't talked much about labor, although I think Rob mentioned it, and you saw it on the slide that showed our increases in expenses over many years. The health plan. So you asked a question about, we have the hospital, the federally qualified preventive care delivery system, and a health plan. And the health plan really works to also keep people in Denver Health as much as they can, although we participate with many other systems. But we think that integrated care and the fact that all of the physicians and all the other clinical staff are our employees takes out some of the profit motive that you perhaps were referring to when you started talking, when your chief medical officer started talking about, systems buying up practices or private venture coming into the physician world and paying docs a salary and building a culture within Denver Health, I think really contributes not only to affordability, but to the quality of care.
Dr. Lisa, heads up, I'm about to ask for your thoughts on this conversation here. So this is really important. I have the privilege and the scars from having dealt and done business in all 50 states. And you go into one state and you go into a whole other country. So when you go down into New Mexico, you have this huge Loveless system that used to be owned by Cigna and then Blue Cross, and you go across the street and you have a Presby system. It's owned by the providers, and you have this dual. You go to Pittsburgh, you sort of have something a little bit the same. You have Allegheny system and insurance. They're a little insurance company too, and then the Blues. You go into Utah and you have this big Select owned by a hospital system, and so it's very different. Colorado has not traditionally had that behavior, nor has Wyoming. And Margot, you know that world down there. You had a health plan for a little while in Wyoming. It's something for us to think about because it brings so much the ability. What I'm hearing you say is when you're trying to better control your cost, you're not always sure it's actually being passed by the middleman on to. Kaiser has a good system where they have, Donnie, you come right out of there, where they got their staff model and then they have relationships with hospitals. And it's an interesting dynamic and something that we've got to study. How do we get from value-based payments and everything that we're working on into a different tomorrow that might have more risk taken by hospitals. So you can actually translate the good intentions that you have when you're really trying to work hard to course correct and be part of the solution into premiums that people pay on the other side. Dr. Lisa, I just want you to share your thoughts on this conversation. I know you're right in the middle as a practicing physician as well.
Yeah, thanks, Kim. So just for all of you, I am a practicing physician. I work here at HCPF, but I also have an independent practice in Denver, and I've been practicing in our community for over 20 years. This is a super important conversation. As we look at practices being acquired by hospital systems, there becomes sort of this interplay of an inability for private practices to keep up with employed providers. We can't compete with the salaries that are paid by hospitals, and we can't compete with other fees that can support those independent practices, that can support those employed practices. So that plays a role in sort of this inability for independent practices to stay open, and then they end up being employed by the hospital systems as well. So that sort of leads to this greater number of acquired practices. So we see that happening. And then we also see that as we're trying to drive down total cost of care and improve affordability in the state, we really need to engage our hospitals at a much higher level with our value-based programs. So right now, the biggest focus is on primary care providers in regards to value-based payment outside of our HCP program, but we need to see more value-based work happening across the commercial payers as well, so we can really get a handle on our cost of care.
Really appreciate that. Thank you, Dr. Lisa. I want to move us a little bit to that labor issue, Donna, so we haven't talked too much about labor and your costs. So the whole world changed on you through COVID, right? We used to say as the studies came out that 4 to 5 times more moms left the healthcare workforce than dads, and like the criticality of the workforce that you have was women. And so I just want to maybe go around the horn a little bit and talk about how have you managed through and navigated this workforce, and how do you think we need to, and by the way, I've moved into some of the questions coming in from the audience. That was curious to a lot of the audience. So I'm going to start with you, Dr. Rob Vissers. How have you navigated this workforce issue with such an increase in cost in the workforce, and where you are now as a baseline? Thank you for your thoughts.
Yeah, and in healthcare, we have no greater asset. There's nothing more important than our workforce, or probably better referred to as our caregivers and our providers. Every single person, regardless of the role they play, is caring for the health of our community. And some of them highly talented, incredibly trained, and invested years and dollars to get to this level of expertise. But it's also a huge expense line. And you saw, thank you, Kim, for sharing the dramatic increase. In 1 year, we had our wages went up 20%. And that's tough to absorb when your payments go up maybe 3%. So one of the things that we learned out of COVID, and we learned a lot, and I think we all got a lot better because of it, was as much as quality needs continuous investment improvement, as much as operational efficiency does, so does your HR and your investment in your employees. It needs to be a continuous thing that you're doing every day, and that's really been a focus. I talked about our strategic plan and our focus on the community. The other half of it is really on our employees and their well-being. If I don't have a healthy workforce, I don't have a healthy community that they serve. And we've really shifted our foundation away from buildings and things like that to investing in our community. So this past year, 10% of our margin went to nonprofits in our community supporting our healthcare initiatives. But a huge part of our foundation went towards our employees and wellness. We got a $5 million grant from one individual just to support the education, wellness, and improvement of our employees. And we were able to really invest in that and double down. And that's paid off many, many times over, whether it's reduced turnover, the quality of the staff, the level of compassion and engagement that we hear over and over again. And most importantly, it all translates into better outcomes and better patient experience and engagement. And so the multiplier there is huge. I will put a plug in, though, that you'll hear over and over again from us. And the state will say, how can we support this? Protecting our providers. It has been a tough time, and it's always been a challenging environment to work in, whether it's workplace violence or other things, or frankly, just the hours and working night shifts. But being able to support and protect our providers and also support their wellness, there are opportunities at the state level that could take place.
Thank you. Margot, okay, if I ask you the same question, how are you navigating this labor challenges?
Yeah, very similar to Rob. We got Hope certified in Northern Colorado, which is a really good certification for behavioral health for your own staff. We're on a mission to have zero suicides within our workforce. So, Rob, to your point, the well-being focus, I'm a nurse by background, and the amount of violent patients we're seeing come in is incredible. So we've made very concerted efforts, as I'm sure everybody has, on workplace violence and really paying attention to protecting our front line. Also, partnerships. So important culture work, always feeling appreciative and value, but also with the schools. We took 10 of our nursing assistants and they wanted to get educated at a higher level. So we partnered with our local colleges, which have been Ames has been a great partner. UNC with their DO school. We know rural healthcare providers, there's a shortage, and how can we help there? So we've really been, I think, very intentional to Rob's point, culture first, making sure people feel safe and appreciated, always competitive, watching how we're taking care of our own, but also growing the pipeline in both our physicians and our staff.
Thank you, Margot. It's such an important part. I always say people do the work. Of all the priorities we have at HCPF, I always say that people have to come first because people do the work. They come in with passion to try to do a really important job. And I'm not sure there's more important jobs than the people you have on the front line taking care of Coloradans. So thank you for that. I'm going to close this panel with one more important question. Then we're going to go through about 11 slides and we're going to bring you back on. Kevin, I just want to ask you, this is coming in from the audience. It was surprising to the audience, as we know it would be, that some of the commercial payers are not paying at cost. And the question is a good one. Are they not paying at cost because the costs are too high? Are they not paying at cost because we have a tension and a negotiating power?
Yeah, Kim, thank you. Thank you for the question. And it's a good one and it's complex. By the measures that we have available to us through the transparency data, we know what the payers are paying all the other critical access hospitals in the state. We also know that we are being paid less than the average of those similarly situated hospitals across the state. I can tell you that my charges nationally, according to Chartis, we end up in about the 10th percentile on our charges, and we intentionally keep those low. That's a board decision because we have a community responsibility to make sure that our costs can be affordable by our patients because we have a growing number of uninsured, and the insured that we have an increasing number of patients with high deductible health plans who, again, end up covering more of their cost of care. So I would personally stack our per patient discharge costs against virtually any other hospital in the state. I think we do very well at that. And all we're asking is those costs be covered with a reasonable margin so we can invest in our future. And it is the market imbalance where we just can't get the attention of the commercial payers to say, yeah, let's pay in a reasonable way. And I think we have to take a look at how rural hospitals are paid to make sure their costs are covered.
Yeah, and we've tried to hear you at HCPF, especially at the Medicare Advantage plans. Some of the MA players are so big nationally, and they're not taking your calls. And so we've tried to adjust our contracts with them that I'd signed to say, hey, in this state, you need to answer the phone, blah, blah, blah. And we know you're in a struggle there. So
Kim,
a lot of work to do, especially what you said on the high deductible health plan is really interesting, where the rural might not do that next generation really expensive care where they get outside that high deductible. And so you've got to collect that deductible. And you're starting with a zero payment and got to collect that. And then, yeah, you got a lot of challenges.
Yeah.
Okay. So I'm going to ask our panelists to turn off their camera, and now we're going to go through in some really interesting materials. And here we go. So Kelly, let's bring back up the slide deck. And thank you for that. All right. So we're going to start talking about what is the landscape to come. So we all know that H.R. 1 was signed by President Trump on July 4th, 2025, and it's bringing our next generation of challenges that we've all got to battle through. One of the challenges that's the most critical on the minds of those that were our CEO hospital panelists is the provider tax provision, which reduces the amount of money that comes into the state, which is significant. It finances so much, which Nancy Dawson will go through, but it pays for increasing dollars to our hospital, and it covers about 420,000 plus folks for coverage. So as that goes down, boy, is that a challenge. Next challenge, we call it our North Star. We want to make sure people stay covered to the best of our ability through these two attributes of H.R. 1, which is both targeting the Medicaid expansion populations passed through the ACA. Some of us call it Obamacare. But we expanded Medicaid, and in that 377,000 or so individuals, those individuals now have to be redetermined for eligibility twice a year, not once, or 6 months instead of 12. And they need to engage all able-bodied individuals have to engage in something that adds up to 80 hours during the month. So that would be work hours, that might be going to school, that might be volunteering in the community, or it might be a work program. And those two areas bring concern because they're going to increase uncompensated care as people are disenrolled, either because they didn't take the action or we didn't understand as a state that they took the action and weren't able to properly carry it through. And we're working hard again as a North Star to mitigate any losses caused by that. Eligibility determination accuracy. Clawbacks in H.R. 1 start immediately for even 0.1% over 3%. And at HCPF, every 0.1% over that 3% error rate equals 9.3 million in general fund clawback by the federal government. So you have a 5% error ratio of 186 million in general fund that we've got to claw back and hand to the federal government. That is hard. So we really want to avoid that. They're called PERM audits. There are other factors outside of H.R. 1 that I just want to hit. In the first year of the new federal administration and Congress, there's changes that are outside H.R. 1, like immigration, like health-related social needs, and how the federal government has a perspective of what should we be doing in food and housing. I've talked to the highest people on several occasions, and there's an interest, but how do they do that in a way that seems logical to them, appropriate to them, has better guardrails and guidelines? Planned Parenthood is another example. Audits on hospitals, audits on payers like Medicaid are going up. So there's a lot changing, and it's not all just in H.R. 1. But if you want more on H.R. 1, please join our webinar on the 24th of February. Let's go to the next slide, please. Next slide there, Kelly. Thank you. The consequences if people lose coverage. Care delays. When somebody's not covered for care, they've got an affordability issue. So unless they're really sick, they're probably going to put things off that are really important. Getting your mammogram, getting your colonoscopy, getting that preventive care, not filling the drugs that they need for those chronic conditions. And so you have this degradation in health of our population here in Colorado and all across the nation in that 377,000 individuals that we're talking about here, those that fall off the rosters and have that a challenge. And when that happens and they go to seek care, we have debt and bankruptcies. We also have a higher utilization of emergency services. We heard Margot talk about how important it is to get people in primary care instead of that emergency room from an affordability and a quality outcome perspective. We have providers uncompensated care that goes up. Holy wow. And remember, we've taken uninsured rates before the ACA from 15.8 down to a low of 4.6 during the ACA or during the public health emergency, where we didn't disenroll individuals from Medicaid even when they lost eligibility. We kept them on. So we went all the way down to 4.6. And then after the public health emergency, we're sitting about 5.9%. So, we don't want to have happen go back up to that 15.8 or anything even close. Provider access decision layoffs, as we talked about what happens when expenses are going up and revenues aren't there to cover them. Difficult decisions have to be made. And the economy, the biggest part of the American economy here in Colorado nationally is healthcare. So when you start messing with that, all sorts of downstreaming effects hit. Let's go to the next slide, please. So I'm not going to cover this, but it just shows all of the elements of HR 1 that we're tracking related to healthcare and the dates at which they start. I want to recognize that there's retro coverage rollback, so we can't go back 90 days when somebody's eligible. We can only go back 30 days. And qualified alien will lose about 7,000 individuals in October 2026 because of the change of who we can traditionally cover under Medicaid. So lots of, and the prohibited entity funding was Planned Parenthood. Let's go to the next slide, please. Now I'm going to turn this over to the next slide on uncompensated care. And Austin, you are back up.
Thank you again, Kim. These additional HR 1 requirements on Medicaid members, like Kim mentioned before, is going to drive people off coverage. Uncompensated care is something we continue to monitor throughout the various shifts that have occurred over the previous 5 years, from COVID-19 pandemic to PHE unwind to the future in HR 1. In the summer of 2025, uninsured rates at 5.9% are lower or similar to pre-pandemic values, which was 6.5%. And that's from CHI's Health Access Survey 2025. There's also some federal data available in the American Community Survey that points that direction as well. However, uncompensated care costs to hospital providers increased by 31% between 2023 and 2024, a significant increase from previous years, as you can see on that graph on the right. This was primarily driven by an increase in charity care instead of bad debt. And charity care is uncompensated care that hospitals identify in advance when patients are first seen. In previous years, the growth in uncompensated care costs was driven mostly by general inflation. However, between 2023 and 2024, the growth in uncompensated costs have shifted and is now driven primarily by an increased volume in hospital providers. 46% of the uncompensated care cost increases between 2023 and 2024 were driven by 4 large hospitals in the following order: Denver Health with $33 million of growth, UC Health University of Colorado Hospital with $20 million of growth, Common Spirit St. Anthony's Hospital with just under $12 million, and Children's Hospital Colorado with $11 million of growth. These hospitals notably...
Austin, just your camera's not on there. Is there
Thank you, Kim. Sorry about that, folks.
No worries.
Is that fixed? Thank you. You didn't get to see my lovely smile. Notably, all those hospitals that are driving the uncompensated care cost increases are profitable despite the increase in uncompensated care cost. Next slide, please, Kelly. I'm going to get into a little bit more detail on uncompensated care costs here in the table, which is really important to understanding how these uncompensated costs affect our hospitals. Denver Health is responsible for a large portion of uncompensated care costs within the state for several years. As a standalone hospital, Denver Health provides almost a quarter of uncompensated care costs in the state and approximately 41% in the Denver DOI region, which includes Adams, Arapahoe, Broomfield, Denver, Douglas, and Jefferson counties, where 21 other hospitals are located. They're providing 41% of uncompensated care costs. The providing of uncompensated care by hospitals is very different than the proportion of beds each system has. On the right-hand side of this table, Denver Health only 4.4% of statewide beds, but almost a quarter of uncompensated care costs throughout the state. There's a real opportunity for other hospitals to step up their services and do their fair share here, or even above their fair share, especially with the upcoming growth that may happen because of HR 1 and other federal changes. Now I'll hand it off back to Dr. Rothgary to talk about community benefit spending.
Thank you, Austin. So I'm going to talk for a minute about community benefit. And first, I just want to highlight, what is community benefit? Community benefit refers to actions that hospitals take addressing community needs that allow them to qualify for tax-exempt status. And then it also refers to the dollar amount or expense spent on those actions. So hospitals spend a significant amount, $1.44 billion in 2023 on community benefit. Hospitals report community benefit investments in different categories, and you can see those in this pie chart. The 1.44 billion in community benefit identified on this slide is 8.2% of patient revenues. And then when you include the Medicaid shortfall, that number increases to 15.9% of patient revenues. As you can see in this sort of lighter blue section, currently the largest focus is on provider recruitment, research, education, and training, making up about 62% of community benefit spending. Some hospitals and health systems are spending a lot of money on recruitment, and it can be difficult, though, to really understand the impact of this investment, particularly to the local community. To better understand this, HCPF is going to work with our hospitals to increase transparency on the effects of this $895 million spend and learn more about how that spending is increasing providers in Colorado. As I mentioned, hospitals invest in their communities in lieu of paying taxes, effectively serving as the community's healthcare budget committee. So these reports also compare community benefit activities to an estimated tax liability. Due to low profits in 2023, community benefit spending vastly outpaced potential tax liability. The reports also review if the spending aligns with community health needs assessments, or CHNAs. You heard Dr. Vissers mention those assessments in the panel earlier. One powerful finding from the reports this year is that 17 hospitals didn't invest in one of the prioritized community needs, which was behavioral health. However, the 2026 HCBA report found that 9 of those hospitals allocated behavioral health activities into different investment categories. So future reporting really needs to look at illuminating where community health initiatives might be differently classified to help communities fully understand the hospital's community investments. Next slide, please. Because of recent legislation, HCPF now has more information related to hospitals' community benefit spending, which includes insight into where the money is actually being directed. This shows how hospital system investments into different community benefit categories for 2023, and you can see the community benefit categories are sorted as percentages of net patient revenue by healthcare system. The graphic allows us to compare if the largest areas of spend match what hospitals have outlined as top priorities based on those CHNA community health needs assessments and community meetings that you heard us mention earlier. Again, as you can see in this lighter blue color, the largest category for most systems is that provider recruitment, education, research, and training category. Whereas the top 3 community benefit identified needs were behavioral health, access to care, and chronic conditions. Behavioral health was prioritized by 85% of the community, but only 1.9% of community benefit investments were in that category. This tells us that there's a major opportunity moving forward to better align hospital community investment spending with the voice of the community. Another opportunity for us to pursue in partnership with the hospitals is a better understanding of how the provider recruitment, education, research, and training category aligns with the specific types of care access needs of the community. So for example, is recruitment and training supporting growth in primary care, nursing and behavioral health, or other areas of known shortage? And finding those answers and driving alignment between provider recruitment and training with provider shortages and access needs is another opportunity for all of us going forward. Nancy, I'll pass this to you next.
Great. Great. Thank you, Dr. Rothgary. Good morning, everyone. My name is Nancy Dolson. I'm the budget director here at HCPF. An important way we support Colorado's hospitals is through the Colorado Healthcare Affordability and Sustainability Enterprise, or CHASE. Through CHASE, we collect fees from hospitals to draw federal matching funds, which reduces uncompensated care by increasing hospital reimbursement and supporting coverage for Medicaid and Child Health Plan Plus, or CHIP, members. In the most recent year, we collected $1.4 billion in fees and paid $1.9 billion to hospitals in direct payments that increased their Medicaid reimbursement by $483 million. In the most recent year, CHASE funded coverage for 439,000 Coloradans under Medicaid, CHIP, and a Medicaid buy-in program for persons with disabilities. Because of the higher federal match rate for Medicaid expansion adults, the provider fee only pays 10% of the share of that population's coverage, as you see here, with federal funds making up the other 90%. By funding this expansion coverage, Chase reduces the number of uninsured Coloradans, and hospitals benefit directly from that coverage as well, where they receive claims payments for patients who may otherwise be uninsured. Next slide, please. Now, with the passage of HR 1 this past summer, there are significant changes that will affect Chase. Currently, we can collect fees up to 6% of hospitals' net patient revenues. Under HR 1, beginning in October 2027, the amount of fees we can collect will decrease by 0.5% each year until we reach a 3.5% net patient revenue fee limit. At that point, we estimate we will have a shortfall of more than $850 million in fees each year, compared to what we could collect if the limit remained 6%. Under the Chase law, there is a hierarchy for the use of hospital fees, with payments to hospitals funded first before healthcare coverage. So this means as the provider fee ratchets down, health coverage would decrease due to insufficient provider fee revenue. In terms of dollars, because of that higher match rate for Medicaid expansion population we saw on the last slide, a loss of $853 million in fees would reduce our federal funding by approximately $3.9 billion in 2032. This phase down of the provider fee revenue will increase uncompensated care. There's no way around that. At the same time, HR 1 imposes new requirements for Medicaid expansion members beginning in January 2027, as Kim mentioned. These requirements include that community engagement, aka work requirements, and twice a year eligibility redeterminations instead of once a year. These new requirements will decrease the number of members covered by Medicaid. This upcoming Tuesday, February 17th, we'll publish our updated caseload forecast, which will include our estimated enrollment changes due to HR 1. We'll continue our analysis of the HR 1 impacts on both the ratchet down of fees and loss of member coverage. But the bottom line, there are significant changes coming to Medicaid and our Chase Hospital fee program, and we'll continue to keep you updated on developments. Now I'll turn this over to my colleague Shannon Huska to talk about the hospital hospital transformation program. Shannon?
Thank you, Nancy, and good morning, everyone. My name is Shannon Huska, and I am the Acting Special Financing Division Director. Hospital Transformation Program is about more than just meeting performance metrics and financial reimbursement. It is about our hospitals being intentional about workflows, process improvements, and care coordination to drive quality and affordability. Hospital Transformation Program is in program year 5, and we are currently scoring performance for program year 4, which is our second of 3 performance years. This is because the first 2 years were to get the program set up and allow hospitals time to put their interventions in place. The Rural Support Fund has provided $60 million to rural hospitals and was recently extended for an additional year and an additional $12 million. This is to help support rural and critical access hospitals in Colorado. The Rural Support Fund will end in September of 2026. Next slide, please. Progress continues to be made as the Hospital Transformation Program continues in year 5 of the 5-year program. There have been and continues to be robust activity and engagement. There are exciting results that highlight Colorado hospitals' continued commitment to improving the quality and affordability of hospital care and engaging with the communities they serve. Throughout the Hospital Transformation Program, hospitals have had over 16,000 different interim activities across all hospital interventions and are on track to meet future milestones as the program continues in year 5. Hospitals have also made significant community and health neighborhood engagement progress under the Hospital Transformation Program. Overall, this illustrates that hospitals are making strides in connecting with their community and partner organizations on pertinent hospital transformation topics. HCPF is pleased to share with you all the robust progress and engagement from hospitals in the Hospital Transformation Program, and you can find more information on the link at the bottom of the slide. Next slide, please. A couple examples of how we've seen major successes that have highlighted the tremendous work put in by the hospital quality teams to truly transform care delivery. The first one is follow-up prior to discharge and notification to the RAE within 1 business day. This measure has increased by 56% from program year 1 to program year 2. This shows better coordination with the hospitals and the RAEs, which means for the Health First Colorado members, they are being integrated into the managed care system sooner, which helps them access care when needed. Another measure, social needs screening and notification, has increased by 52% from program year 1 to program year 3. Social needs screening during visits helps to determine patients' ability to pay and therefore can reduce uncompensated care on the hospital side, and additionally connects patients with services available to them that they qualify for. Lastly, the last measure we'll highlight is using alternatives to opioids in emergency departments. This has increased year over year from program year 1 to 3. It increased by 22%. This measure helps reduce exposure to addictive medication in emergency department settings versus being prescribed in a controlled setting, which can lead to adverse health outcomes. Next slide, please. And we're going to take a moment to do another poll about leverage, what you're excited for in the new hospital discounted care. Please select up to 5.
And then you can keep rolling.
All right. On the next slide, we are talking about leveraging federal funds. In collaboration with the hospital community, we identified a way to increase payments to hospitals who serve Medicaid members who are enrolled in our managed care program. To finance the state share of these payments, we've worked with state hospitals to use some creative financing mechanisms to be able to make these payments without increasing or reprioritizing provider fee funding. This mechanism is referred to as the state-directed payments. The proposal is currently with CMS as we await approval. Once we receive approval, we will implement the payments. We've been in communication with CMS to answer any questions they may have regarding the state-directed payment proposal. Excuse me. We will continue to meet with stakeholders and explore other opportunities to draw down additional federal funding as they become available. Next, I will turn it over to Kristen Bates to further discuss leveraging federal funding.
Hi, good morning, everybody. We can go ahead and go to the next slide. My name is Kristen Bates, and I'm our Deputy Medicaid Director here at HCPF. And I'm really excited to talk to you about one of the few federal funding opportunities that we do have right now. Our Rural Health Transformation Program, or RHTP. This is one of the largest grants that the federal government has ever given, and each state gets around $200 million. So we submitted our grant a few months ago. We got our award letter in late December, and we were awarded just over $200 million a year, meaning there's going to be $1 billion coming to Colorado specifically for stabilizing, supporting, and innovating in rural health spaces through September 2031. So while we have gotten our award letter, we're still awaiting our final approval on the budget. And we expect to get that by March 2026. And again, these funds go all the way through September 2031. We should expect the money to start coming. First, we have to get a couple of things done. One, we have our advisory committee accepting applications right now. And the advisory committee is really made up a lot of our eligible providers. So rural hospitals, community health centers, federally qualified health centers, rural health clinics, comprehensive behavioral health providers, opioid treatment programs, and EMS services. Those are our areas, and then those are going to be focused on individual providers who are serving and working in rural areas. So we have our rural providers, consumers, public health, education, and state leaders who are going to come together on that advisory committee. They're going to help us create a request for applications. And those requests for applications should come out somewhere around April. My request to all of you is the next slide. I'm going to talk a little bit about the priorities. Go to our website, learn about the grant, and start planning now. We would love it if when we put out these applications, there will be about 60 days to complete. But you should be ready with some ideas. Hopefully you have your partnership set up. We anticipate a lot of providers will have individual applications, but a lot of the work requires partnership. So it might be a rural health clinic and a behavioral health provider and EMS and a hospital working together to build out their community delivery program to improve the outcomes for their community. And, we know this won't make up for the HR1 impacts, but I do think a lot of us recognize that the needs of rural providers in Colorado are significant. And so we can go to the next slide and I'll tell you a little bit about these sections. My background is public health, and I'm really excited to see the public health focus in a lot of this, right? Make rural America healthy again is really the prevention and chronic disease goal of the program. It looks at transforming rural care, building data infrastructure to better understand the needs of the community, and expanding preventative care, both primary prevention, community health, as well as chronic disease management and chronic disease supports for those who are needed. We also have, and if you can see on the left, you have the total amounts that we have for each section. Sustainable access is a really big one. This is really looking at hospital stabilization and access to care, building out EMS networks, grants for hospitals, regulatory readiness. What that means is a lot of requirements for hospitals, a lot of safety net providers. Sometimes it takes some time to get adjusted. So updating your regulatory structures and your policies and procedures, creating referral networks, building and strengthening those delivery system partnerships, and specifically focusing on hospital operations. Workforce, we know workforce is a serious issue in rural areas. I think that this is a really special place because there's both that kind of grow your own, build out education models in your community so that people can join the workforce, but also improving and strengthening existing workforce members with credentialing, additional health programs, clinical trainings, recruitment, and retention offers. Innovative care is a lot of pilot and value-based care. So that value-based care is looking at what are the payment models, looking at maybe shared savings models, bundled payments models, and some of those, the way that we design and deliver care, how that can work across providers as well. And then finally, innovation, and specifically tech innovation. We know that technology is an essential part of extending our limited workforce and resources in rural areas. So how can we improve technology? How can we improve our tech capacity, improve cybersecurity, improve data, connect through health information exchange, and better connect with some of our social services as well. So again, my request to you, don't be just ready to apply, be ready to sign. Make sure that your contract and your legal teams are involved in these conversations that you're having. What we really want to make sure is we are getting these dollars out the door, and not only are we ready to award the dollars, you all are ready to contract for and receive the dollars, and then spend the money as soon as possible. This grant is more strict than a lot of other grants that I've worked in, and I've worked with a lot of federal grants in my days. This is even more, much more restrictive than the American Rescue Plan funds. So read about what the restrictions are. We're going to help you understand. We're going to have webinars. Go to our website. We've got all kinds of education materials there. And that is where we want to make sure you all are ready to go, because if we don't spend the money, they're going to take it back. So they've said, maybe we don't think states are going to spend the money. We're going to spend the money. We're going to do it. So I look forward to working with you all to do that, and building out the extraordinary work of our rural partners. All right, and I think that we have our last poll up on what are the 4 most important priorities over everything. Then I will pass the mic back to the MC.
Thank you, Kristen. Let's bring Kelly, please bring our panel back on of our hospital CEOs. Okay. So thank you all for hanging in. This is where the rubber's going to meet the road a little bit. And so looks like we have everybody up. So just in 10 seconds or less, can you just rattle off? We're going to go around the horn. What's the most concerning provisions associated with HR 1, like the provider tax or uncompensated care, or blah, blah, blah. So what are the most concerning provisions that you have? Let's start with Margot.
For sure, the provider tax.
Kevin.
Same, the provider tax and the resulting increase in uncompensated care that we're all going to have to deal with.
Rob.
I don't know. There's so many bad things. I think the provider tax, but it's really the ripple effect of taking $1 trillion out of American healthcare. It's hard to quantify.
But, yeah, Donna.
They're also related. I'd thumbs up on the provider tax, but when we lose the money, we see disenrollment in Medicaid and we see more uncompensated care. So bingo, all of them. And we help enroll people in Medicaid. So I know there'll be an additional administrative burden on us, but we're going to work really hard to keep everybody enrolled that we can.
Lisa's our CMO. I'm going to ask you the same question.
I think I agree with all of them as well. I think the provider tax is the most concerning.
Okay, thank you. I'm going to start with Margot again. How are you preparing for HR 1? What do you need from stakeholders or listeners and the state to help you prepare?
Yeah, so just, and probably everybody's doing this, we're running our P&Ls right now, taking out the hit. We're probably going to be a -4 margin, so a really clear understanding of the impact on our financials. And then I really see this, Kim, as catalytic, that we're going to have to partner with the state, with all the rurals, urbans, true safety net, defining what does that look like in our state, really pushing hard on that definition, because we all take the vulnerable, but as we learned today, Donna takes a large percent, rurals do, and then there's pockets of us that if you look at a percent of payer, we're not going to survive because our commercial percent is so low. So really coming to the table, trusting each other, working really close with our FQHCs and figuring this out and studying, are there other models out there that can help us at the federal level?
Thank you, Margot. Yeah, lots to think about, lots to prepare for. Dr. Rob Vissers.
You know, I think it's broad-based. Every organization is going to be impacted, and sadly, every Coloradan is going to be impacted. Sometimes we like to think of it as pockets, but when we have such an increase in the number of people that are not going to be able to access Medicaid, that are going to be uninsured, in order for us to keep access to everyone and provide life-saving emergent care as well as hopefully preventative care, it's going to require hard decisions and cuts. And whether it's at the state level or whether it's at the health system level, and we all share in this. If Donna's can no longer accommodate the number of people that don't have care, they're going to seek and appropriately seek care elsewhere. And so sadly, we have to look at services that we're going to need to cut. It's just there's no other way around it. There's not enough dollars to serve everyone, at least in the robust way that we've been able to so far. I guess what I would ask is, in partnership with the state, we've all made significant investments in access to care for un- and underinsured, in behavioral health, in pediatric care. But all of those things are under-reimbursed, and the areas that any business person would look at and say, those are the places I got to cut because that's where I lose money, and I need to prioritize the areas that make enough money so that I can keep the doors open. anything that we can do to preserve those services that care for all those things I listed, behavioral health, geriatrics, you name it. That we need to do that as we ride through this challenge, and anything the state that can do to help us to prioritize that, and work together with the hospitals to make the hard decisions that we're facing.
You. Rob, yeah, tough times ahead, and I appreciate what you're calling out. Kevin.
Yeah, I agree with everything. I think in addition to the hard decisions we're going to have to make, we also have to be thinking as creatively as we ever have. I think we have to evaluate new delivery of care models, things like direct primary care. What are maybe some subscription services we can offer our patients to help them get access to primary care, to try to create some level of compensation for it for those that can afford it. I think the partnerships, as Margot mentioned, across the state, allowing more collaboration amongst and between the rural providers and our urban partners to make sure care is provided in effective ways, driving up quality as much as we can, and all the while controlling costs. And I totally agree. Rob particularly talked a lot about needing to make these hard decisions. We have to make those decisions, but we cannot let that overwhelm us. We have to be creative, and we have to learn from other states, and we have to learn from other models. What can we do differently in Colorado? Because we have absolute obligations to the communities that we serve. And we've got to make sure that there is access to care in those communities.
Thank you. Kevin, Donna?
Yeah, I think if we could model out, not individual hospitals, but as a state, what's going to happen over the next 3 to 4 years, because we haven't felt the direct impacts of HR1 yet. But as you know, state budgets are built a year and a half to 2 years in advance. We have complicated tax questions in Colorado with Tabor. But I think if the general public and some of our lawmakers could understand, we're not crying wolf. I mean, the bottom is going to fall out. And I think we owe them, the people that make decisions, whether they're voters or they're legislators, we owe them a true picture of what this is going to look like 5 years from now. Because it'll be a slow, it's not falling off a cliff. It's slow, although I would say moderately slow in terms of the impact. So I think we need to assess that. One thing that might be controversial, actually, I'm going to say two things that are controversial. The state has a budget problem, and they've chosen to freeze provider rates. As you know, for fiscal 26, we are basically getting a 0.4% increase in provider rates. That's going to have a negative impact, not just on profits and cash, days of cash on hand, but it's going to have an impact on services. And then the projection for fiscal 27 is zero. And it just can't be borne on our backs. And I know the state's got a huge problem, but we need to figure that out. The other thing is, I was watching your slides, Lisa's slides, on community benefit. I think there's some money in that community benefit pie that could be shifted a little bit more towards uncompensated care. I'm not saying that training providers is not important, but we don't always train providers who stay in the state. There's no relationship, or there's little relationship between that. So, or if it is, then we ought to have some connection to retaining providers in the state. So I would suggest that community benefit be spent more on uncompensated care.
Really appreciate that, Donna. When you have more than 800 million going into one slice of that pie that we showed that was so dominant, we really have to reevaluate what's the return on that investment. That's what Lisa called out. We don't know. And we need those optics to figure out what's the trade-off and maybe how long will that be. The other issue is, how long will this work requirements aspect of HR1 continue? So we all have to watch and see what the outcome is and what society decides to do. All right, moving to the next topic, big topic, So Chase, you saw Nancy go through how the numbers are going to change. And so we have this unique dynamic that's happening. We have, when we showed that net promoter score is one of the first slides, I'm sorry, net promoter score, listen to me, net patient revenue. One of the first slides that I just kept going up, and expenses for hospitals were going up right in parallel. And so those expenses sort of keep coming, and all expenses for healthcare for our expansion population, they keep moving at a trend. At HCPF, it's running around 8%. We're trying to get that more down towards the 5%. But the net patient revenue moves up. We calculate how much money we get from the federal government using that very important factor. The percent that we can pull down is going to keep coming down, but our claims under expansion will keep going up. And our claims under people with disabilities who buy in will keep going up. And so the monies are going to come down, the claims keep coming up. So we should start with understanding that the department, in collaboration with the legislature, the actions we're taking now because of the budget shortfalls now will help us mitigate some of the claim trends going forward, but we still have to battle. So as Kristen Bates, leading our behavioral health initiatives, tries to get that trend under behavioral health better, it will relieve some of the pressure on our Chase dollars. As we move NEMT out of that expense line, and we'll get some GF relief, and it'll remove some of the pressure. As we've already suggested, it's just so horrifying, it's $780 million in Medicaid reductions. As those are implemented, that will start to bring some relief on what the Chase dollars have to finance for the 429,000 people under there. So we're already taking actions which should have some impact, but boy, do we have a problem emerging. So here's the question. Chase has helped increase our hospital reimbursements to that one of the first slides where Austin said our reimbursements to hospitals for as a percent of your cost went from 54 cents in the dollar under Medicaid to 80. So lots of money is coming to the hospitals. So we're not paying you half of your cost. We're paying 80. We're not paying 100%, but we're paying 80. We're also covering financing for 420,000 Medicaid and CHIP members and the people for buy-in with disabilities. At the same time, we have this great divide between those that have low reserves, or hospitals that have low reserves, big systems. We show different sorts of profits. We have some national systems with 200 hospitals, and then we have rurals with one hospital and averaging 3 patients in a bed. Boy, do we have difference here. So given all that, as the federal funding decreases in HR 1 tax provisions, how do you see us working together to navigate these challenges? And do you have solutions you'd like to share? Let's start with Kevin.
Well, Kim, thank you for that blessing.
Whichever. And I want to say that Shannon said the Rural Assistance Fund will end in September. I want to correct that because I thought maybe you were having a heart attack and we had to move you down to a bed in Lincoln Hospital.
Thank you.
Just that version is changing, and we have to figure out the next version as we move forward. So anyway, back to
you. Yeah, thank you for that reassurance.
yeah.
It's sort of what I talked about earlier. I don't have any hard and fast suggestions right now, but I think we have to solve this problem collectively. We have to strengthen the partnerships between the state and the hospital to come up with reasonable solutions. But before we do that, we have to understand the challenges that everyone is facing. My challenges are very, very different than maybe what Rob faces or Margot or Donna, but they're not less important for the communities that I serve. And as was noted earlier, when you see one rural hospital, you've seen one rural hospital. So I think we have to try to drive to our communities and find out what are the services that we should be providing in our communities. And then I think we have to work together across the system, if you will, to make sure that those services are provided in a quality but affordable way. And that sounds like utopia, but that is our only solution right now. The other thing I would say is we have to be absolutely creative to continue to look for ways to maximize the federal dollars that come into the state. We have to continue to advocate for those because without these funds, it's not a sustainable model whatsoever. We just don't have that ability to survive without the Chase funds.
Thank you, Kevin. It is so critical. And when we're sort of doing those models as a percent, compared to what the rurals give in, they're getting a much higher percent than what the bigger systems are giving in and getting. So yeah, hard decisions ahead. Donna, to you.
Well, I'm drawn back to that slide where you showed that we have 174 million in uncompensated care, which is greater than even, I mean, bigger hospitals, bigger systems that are supported in other ways. So that's the first, before I even start thinking about your problems or the problems that you laid out with Chase and with the federal cuts, I got to figure out how to solve that. We recently got our Denver voters to approve a tiny increase in the sales tax, although it's still painful because the sales tax is regressive. But I think they recognize the importance of the work that we do. But that impact is only, it's about a third, a little, just a tiny bit more than a third of the total uncompensated care. So that doesn't solve the future problem. I think to Kevin's point, we got to come together in some way. And I mentioned before, can we model how is this going to impact, even if it's something people poke their fingers at, what will happen in 2027, 28, 29, even 2030? We have new governor coming in. That person will need, I think, a really strong health policy. And it's funny because health policy is so complicated. I often say that candidates don't like to talk about it because there isn't an easy solution. But that individual is going to have a blueprint to help us all think about, again, educating the legislators, educating the voters, business community, because the business community is going to be impacted. To Kevin's point, it is going to have to, the survival of some of the hospitals in our rural areas is not just about providing healthcare, it's about providing jobs. So if some of them fail, the economy of those communities suffer. So I don't think we have an easy solution. We've gotten some additional money. It's helped us, but it's not going to help us going into the future. I mentioned the provider rates before. I think we've got to think hard and long about what impact that could have. And of course, if we can go on a treasure hunt and find some more money somewhere, and I know state-directed payments will help us, but we also face a downturn in terms of the provider rate, the provider tax. So I'm a little pessimistic about what we can do going forward unless we really create a public outcry and hopefully a governor and a legislature that is going to say this is as important as some of the things that we've invested in as a state, like early childhood education. This is our health care. And I think we need to recognize that even though it's a pretty much private system, we all have a stake in it.
Appreciate that, Donna. Thank you. Rob.
It's a challenging problem, and I think if we're dealing with something like this, something this seismic and huge, it's going to require us to address all aspects of being solvent, but also maintaining access and quality and safety. And if you look at, even if we're successful in getting an increase in state-directed payments, so let's try and increase the amount of money coming in, whether it be taxes, state-directed payment, shifting the budget. It's not anywhere close to covering the loss to the state that we're going to experience over the next 5 years. It is not $10 billion. And so we're going to have to, again, make some challenging decisions or choices going forward. You could look at operational efficiency. After coming out of COVID, after coming out of hyperinflation, my average margin over the last 10 years is 1.5%. $6 million a year is my margin. You can call it profit. That's maybe 2 of Donna's MRIs and the people to staff it a year. It's not coming. We've squeezed everything we can operationally and from an efficiency point of view. And we don't have a lot of money to invest in innovation like we're talking about. And so I think it looks at where are we wasting our dollars? And I'm going to say something that, like Donna likes to say stuff that's controversial. I'll say it as well. There is plenty of money in healthcare to take care of everybody and provide and continue to provide world-class care. It's where we're spending the dollars. Now we're going to have to look at the Chase Fund and say, Are we still meeting with those extra dollars the priorities that initially was set out for? Are we serving as many Coloradans as we can to provide Medicaid? Are we making sure that the hospitals are supported through this, that are providing the fees to achieve this funding? But also, I love that slide that you had, Kim, that showed the percentage on administration. When I look at, so I'm probably, somewhere between Kevin and the average. The smaller you are, your administrative burden is greater. Every time someone says you got to report something, I got to have the same number of FTEs as a 10 hospital system to get that thing done. So I'm probably more in the 16, 17%. More than half of my administrative burden is trying to get paid from the payers, and meeting regulatory requirements. Far more than half. If we can get rid of the denials, the prior auths, the fact that the average health system is spending 4 to 5% of their revenue just to get the payers to pay them, is outrageous. And we've all experienced the challenge of denials and prior auths. We looked at Medicare that underpays. Our Medicare Advantage pays 6% less than Medicare. Just getting that 6% back, we're more than half Medicare. Getting that 6% back, that's 3% increase in my revenue. That could probably cover a lot of the losses. So the money is there, but it's being spent in the wrong places. For me to spend more than 10%, just trying to get paid, to try and meet regulatory requirements, to address the challenges of the 400 pieces of healthcare legislation that's been brought forward in the last, 5 or 6 years, well intended, probably some of it providing great benefit, but the administrative burden is excessive, and that's a real opportunity for us to work with the state. I know it's a challenge. Some of this is federal, which is why I'm on the American Hospital Association board to try and solve some of this. But a lot of this is solvable at the state level, both in terms of administrative burden, but accountability to the payers. So that's where I see there's great opportunity to try and offset some of this lost revenue.
Rob, I feel like I need to play that recording of what you just said over and over again, because you hit on so many things. There is enough money. And I think about, half of our spend for prescription drugs is on 1.5% of the drugs. What are we doing? And paying so much more than other countries. And what you're saying about denials and how do we, a lot in front of us. And we did, Kevin, we did, Rob, Margot, I don't think I got you on this one, right?
Yeah, I'll go really fast, you guys.
No,
I'd
no,
echo.
you don't have to go fast, because I want to invite you also to say with Chase, I know you're working on maternity and driving that because it's so important. I don't mind if you also touch on maternity and how might be able to use Chase to help support those
Yep.
hospitals doing that labor and delivery.
I
Yeah.
think, Kim, honestly, I said it before, this is catalytic, and we're going to have to take our defenses down and be curious and very transparent. And Kim, you'll know this about Chase. Just tell us truly what is the admin burden to administer Chase, and let us creatively talk about that. Also, then, as facilities, who are the true, and I feel like a broken record, Donna, who are the true safety net facilities? Who has a 70% or higher government or self-pay mix? And those are the ones we have to help you guys. Because if they go away, all our vulnerable patients are going to find other resources, and it's going to be more expensive for the state and hold pharma and the payers responsible, especially Medicare Advantage. And I see a lot of defense played in Colorado. We got to take that down, or we're not going to survive. And you wonder about the economic impact. I didn't have a real healthcare background until I took Banner's position, and the fragile margins and the economic benefit and the care that's delivered to underserved communities, we have to preserve that. But we won't if we continue the formula that's being played out. Volume of patients doesn't matter. It's percent, you guys. You cannot get a margin when you're running a facility like Kevin and it's an aging plant. So I think defense down, collaboration up, transparency true, and that's the only way we're going to get through this. And then to your point, Kim, OB, hard. We have easy 70% Medicaid babies in our NICU in Greeley. We can't cover it, and yet I won't walk away from that program. And the way in which Chase is helping has covered some of our loss, but I'm a preemie mom by background. I will not let a mom travel down to Denver if I can't, because it's going to break the family and it's going to be more burden on everything, employment of that poor mom and parent. So OB needs help. Rural OB needs a lot of help. And we can get through it if we look at the greater whole, not what's in it for ourselves.
Thank you, Margot. Really appreciate that. Donna, anything to add?
No, you got me.
Yeah. Okay. I
Thank
saw
you.
the curiosity on your. Okay. Okay. Um, so Kevin, this might cost you 10 years therapy, but I'm coming at you anyway. Okay. So we have the Rural Health Transformation Program, and I have watched you over, I don't know how long we've been working together. So I think it's our ninth year, maybe. Really do everything you can to lobby at the federal level with national attention. Like turn on the news. Hey, there's Kevin Stansbury in national news and whatever it was, MSN, whatever. Um, here you are lobbying to get more money for rural facilities because you've done in the margins to Margot called him a plant, right? Redo your plant. And so I just want you to walk us through a little bit. What was disappointing when the rural transformation came out compared to what you wanted, but also what's really exciting about the rural health transformation program? Like I called it,
Kim,
you have
again,
various stages of grief.
yeah, thank you.
Yeah.
I've been in therapy a long time. It will continue. First of all, the disappointing things. I think when the bill was first discussed, Senator Collins introduced it as a way to offset some of the losses due to Medicaid. She recognized that rural hospitals across the country were going to lose roughly $150 billion just for rural hospitals and Medicaid revenue because of HR 1. The 50 billion is not enough. One of the things I really worry about is that there's an expectation, and I hear it from state policymakers. I'm in DC now. I've heard it from DC policymakers. What do you want? We're giving you more money than rural has ever gotten in one tranche. It's not enough because you're also taking away 3 times that amount from our revenue from an already fragile system. The other thing that really concerns me is the restrictions that have been placed on what the money can be used. Our hope, and I think the original vision of Congress was we want to prop up fragile rural healthcare systems. Hospitals oftentimes are the center of that. They're now supporting EMS, they're supporting behavioral health, they're supporting public health because those systems have withered away and the hospital remains while not having great resources relatively, it has more resources than those other community services. And so they end up taking those things over just by default. And so it's not enough money. The restrictions are too tight. And I think we're setting ourselves in some way up for a large amount of failure and disappointment. And frankly, that's one of my concerns is we need to articulate as a state, we need to articulate as a country, what would success look like? And I've not heard that from anybody yet. In terms of what I'm excited about, it's a lot of money. It's $1 billion coming to Colorado. And I think it's our obligation. And I said it earlier, we have to succeed at this thing. And in order to succeed, we really have to understand what the challenges are. Kristen, I'm going to call you out briefly. I want the state to really understand what my challenges are as a rural hospital. Rob kind of said it earlier, but Kristen, you said we need to get our legal and contract staff ready to go. That's me. And in most rural hospitals, it's the CEO or it's sometimes the director of housekeeping because we all wear different hats. So we have to understand what the resources that are currently available and what we're trying to prop up and our level of ability to respond quickly. And we have to be sensitive to those needs. So, because our focus is, and I think everybody said it earlier, everybody on our team is pulling the oars in the same direction to provide care to our community. So we want to use this as a benefit, but we just need a little sensitivity to say, we get it, you guys are struggling right now. Let's make sure we're all pulling together for the success of the program. And I think we need to define success, and then I think we need to go out there and exceed expectations. And it's going to be really, really hard.
Yeah, I appreciate that, Kevin. As Kristen said, we've got rural hospitals and your clinics, rural clinics. We have EMS that's in there. We have behavioral health, the bigger systems, the comprehensive. systems. So there's going to be a lot of folks saying, I'd like to use this for. And one of the learnings we had from ARPA is when we look back with our state budget at the time was like 40 billion, and we got like 26 billion in various forms from the Fed to get us out of that COVID-induced recession. And we look back, what do we really see? And we see lots of little things, but in this, the CMS has said, I want to see improvements in this, and this, these 5 areas. And how do we really define success with this committee that will be made up of recipients and some public health folks and the state sort of making sure we're being supportive and helping you get stuff done. But we really do need to set the goals to make sure at the end of this, with all of these challenges coming before us, that we really use these dollars to address the challenges, to mitigate the risk, hospitals going under, people not getting care, etc. It's going to be hard.
Yeah,
But we're going to pick a good panel or a good committee to do it. So go ahead, Kevin.
yeah, I was just going to say, and let's not forget that many of those solutions are going to be unique to each community. It's going to be very difficult to set a statewide standard for success, because what I need in Hugo is very different than what Linda needs up in Sterling or Brush. And we have to be sensitive to that and have enough flexibility. I realize there are tight parameters around the use, but we have to have enough flexibility to say, let's make Hugo successful, let's make Sterling successful, let's make Aspen successful. And we're just going to have to show that flexibility through this committee you're setting up.
Hey, Kim, I'd like to offer, you gave me a chance and I turned it down, but I'm going to offer up something.
Okay.
Because we've talked about a lot of topics, and you've mentioned behavioral health, although in passing. And then, of course, we have substance misuse, that when I think about, some of the patients that are in the NICU, we do have addicted moms, we have addicted babies. And as Margot was saying, you want people to be employed. You want people to be healthy, whether they're young people in schools, they're moms and dads. And I think we've not spent enough time talking about the challenges we have. And again, I'm going to go back to the business community to think about, what do we do with some of the mental health and substance use issues that we face in our state? And if we weren't spending some of the money that we're spending at the at a crisis moment, we could be, as several people said, there's enough money in the healthcare system. We're spending it in a lot of the wrong ways by treating people who have been addicted for years, as opposed to getting in front of that. So it's a bigger problem than maybe we can certainly solve or talk about in this webinar. But I do think we've got to bring the increase in behavioral health and substance use services that we're all providing. I know for us, a third of our patients have either mental health or substance use issues. And so we're spending time on repeat readmissions, treatment for families that have to deal with this. So I will have to put that on a parking lot for a future conversation, but I know it's a huge issue and it's been increasing substantially. And again, reimbursement's not meeting the expenses that we all have in dealing with this societal problem.
And Donna, if I may, Kim, I agree with everything you said. And for us, what we're trying to do is to integrate that more into our strong primary care base. And that's hard to do. It's hard from a resource standpoint. It's hard from a reimbursement standpoint. But that gets to the community to make sure we're looking at both physical and mental health at the same time and trying to care for the whole patient.
Thank you. Rob, next question is for you. It's on community benefit. And Kelly, while Rob and I are in dialogue here, can you turn on the rest of the speakers, because we're going to open up the next round of questions to everybody, please. So Rob, on community benefit, I want to thank you again for your contributions to the community and the work that you do in community benefit. And we've talked about that big slice of the pie of over 800 million going now towards provider recruitment and training, et cetera. What steps do you take to tie the community voice to the investments you make? And how do you see community benefit investments changing due to HR1?
Well, I think we've talked about some of this, so I don't want to be redundant. I think all of us have the means to listen to our community. I just did a State of the Union in Town Hall last week with a high engagement. We do our community needs assessment, and everyone I know on this panel and all the other health systems do that. I think the important thing is listening to it and responding. When I looked at that graph, let me just do again some math. So over the last 10 years, average profit for us or margin, $6 million. If I had to pay tax on that, I don't know, let's say $2 million, probably less as a corporation. We've spent, I think last year, 70 million in uncompensated, undercompensated, or free care, plus all the other things we give to the community. So I'm pretty sure I'm not too worried about the benefit exceeding the potential tax burden. I'm probably oversimplifying. Um, when I saw the amount on recruitment and training and research, I guess I was taken a little back because I don't know that we put anything in for that. If we do, it's probably small. But I go back to Kevin's comment that how do we simultaneously make the cuts, make hard decisions, pay for all the things, and preserve the great care that we have, yet somehow recognize that we have to innovate, we have to do things differently. How do we embrace AI in a way that supports my providers and makes their work more meaningful and less burdensome and perhaps remove some of that administrative burden? How do we make sure that we have a pipeline of incredibly talented individuals coming to us? And so I probably want to reverse that and say, I think the more that we can put as community benefit would help us an incentive to continue to invest in the right way. Most of the providers that come and provide the great care are trained at Denver Health or UC Health Children or University and Children's, and we rely on Children's for that and the research they do. I mean, the other thing, trying to end positive, is we're on the precipice of some really impressive treatments and therapies that could dramatically shift the way we care for things. Even just in the last 5 years, you look at the treatments in oncology. The last thing we want to do is stifle that. That's our long-term solution, pulling out of these terrible constraints. The last thing I would say around community benefit is we have an incredibly supportive community, and we have a large foundation that allows us to do a lot of these great things. We siphon a lot of that money back in. We just raised $22 million in our last foundation fundraiser. It was for employee wellness, community wellness, and addressing disparities in healthcare. And it was not about buildings. It wasn't about devices. It was all around that. And it was our most successful fundraiser going forward. We can't use those dollars to count towards our community benefit. The only way we can is we have to siphon it through our hospital. We pay for it. It's a workaround. Acknowledge the amount of support that the community and help facilitate our ability to take the dollars from our community and offset some of these things that we know are going to get cut and going to be challenged. And so I guess I would reverse it and say anything we can do to expand the recognition of community benefit and support that, I think is going to help us offset some of these significant challenges we've already spent, I don't know, over an hour talking about. So thanks, Kim.
Thank you, Rob. I've got a question from Emily here, one of the audience questions. Are you considering, all of you and hospitals ask you who might want to answer this for Emily, are you considering using the community benefit dollars to invest to help Medicaid members navigate and meet the new HR1 eligibility requirements? Or if you are, what might that look like?
I mean, Kim, I'll kick in. I mean, our community benefit is essentially uncompensated care. So the flip side, though, is we're in enrollment. We do the enrollment for people in the city and county of Denver. And so we're going to do everything that we can to make sure that we keep everybody enrolled who's currently enrolled, and we bring more people into the system.
Thank you. Catherine Mulready is asking a question about AI. How is AI and new technology impacting hospitals and also HCPF? So HCPFers, I'd ask if you're ready after the hospitals respond. Is there somebody on our side that wants to answer how we're using AI? Any of the hospitals, it's such an important way for us to get expenses better in control to maximize those. Anybody want to share their thoughts on that?
I can start. I suspect that my little hospital probably uses it less extensively, but we are using it. We use ambient listening devices in our physician practices to help improve physician documentation. We are exploring the use of AI in filing claims and working with the insurance companies on denials and getting prior authorizations. The problem that I am concerned about with that, and perhaps it's some of the money we can use through the RHDP, is I don't have the resources to invest. I certainly don't have the resources to develop AI products. I don't have the resources to invest in already developed AI products. So it's an opportunity for a greater gap to grow between the rural and urban, but it is definitely something that we are committed to using as much as we can to A, improve care, and B, reduce some of that administrative burden that we've talked about to help me be more efficient in my operation.
Yeah, I could,
Thank
if I could chime in a little
Please.
bit. I know right now we're looking at some legislation in Colorado, and I think it's well intended, and particularly in every space, but in healthcare, we have to be responsible with this to make sure that we're also being safe and thoughtful. On the other hand, we can't stifle innovation, and my A strategy is the much larger systems come up with really great solutions because we're too small to be able to do that. And so, in some ways, can we make sure we're safe, but also be careful that we're not stifling innovation and preventing us from, and particularly at the state level, disadvantaging us against other states where they might be moving forward with some of these things that can really help accelerate and improve. I will say the ambient listening, basically the documentation tool for our providers, has been wonderful. But most of the stuff I've seen is the payers using it as a way to deny, and then a subset of the payers or a division of them trying to sell us a tool that has AI to help prevent the denials. So it's just another rev cycle arms race, where in the end, I would hope that it would actually simplify things and replace a lot of individuals could be and that dollars could be better spent on healthcare. So more to come in that space, but I guess right now, imminently, is how as a state can we make sure that we're fostering the safe innovation to help us do things more efficiently and, more importantly, remove some of these unnecessary burdens from our providers and caregivers.
And Kim, I'd add that we're doing the same thing, ambient listening, we're looking at rev cycle, obviously better reading of radiology scans. But Rob's point is really important. There are 5,000 hospitals in the United States. There are really five payers, maybe six. They have a lot of money. And so their ability to fight us, it is literally David and Goliath, but maybe not with the same outcome. Now, the state has, I think, as all of your state folks know, an Office of E-Health Innovation that perhaps could be that tool that Rob references that helps us think about how do we deal with some of the smaller players and those who don't have sufficient reserves and look at a statewide system so that we're not behind the eight ball because we can't afford some of the tools. And we also have a talent problem. I mean, anybody who has any knowledge of AI and healthcare is probably going to be gobbled up either by United Healthcare or some of the bigger payers, or maybe even multi-state systems. So we have an intellectual challenge, and we also have the software challenge. And I think the Office of eHealth Innovation, if it were, given the resources, could help us tackle that.
Um, uh, Thank you. Kristen, I'm going to ask you just a couple of questions on the Rural Health Transformation Program. People are very excited about this, as we know, but there's some confusion. So can you say again, just clarify the timing? When will we see the advisory committee? What's the timing to post that grant application so that the eligible recipients can start to apply? And what's the timing you think money will start going out?
Sure. So the advisory committee applications are available right now through the 16th. So we hope to have that advisory committee meeting, very beginning of March, and meeting at a fairly heavy clip at the beginning so that they can really help us say, as you said, Kevin, make sure that the rural voice is really injected into the operationalization, the implementation of this grant, making sure our RFA has the right priorities, making sure that we have all these standards from the feds, but like we get to set what are our evaluation criteria. How are we determining what's allowed? Talking about AI, talking about what is an EHR versus an EHR improvement that is run through other technology, what's allowable, and making those clarifications with our partners. So we hope to get the RFA out in April, but it will probably be late April. We'll need to give people about 2 months to fill it out. And then we need about 6 weeks to review application and do rewards, which means we're looking at August at the very earliest to get funding out the door. I think that the way that the feds have set up the timing, we actually have until September 2027 to spend year one funding. So there's some complicated things there, but if you look on the webpage, you can see a little bit more. So that's the timing. So you should look out in late April for the application with a couple of months for review and a couple of months to complete, and then a couple of months to review and award.
Awesome. Thank you. So Margot, next question for you on state-directed payments. Austin and Shannon and Nancy, anyone you can be follow-up to this. But obviously, we've all said, boy, this is a big hit on revenue because of the provider tax plus growing uncompensated burden, and we need to do what we can to open up other doors for federal dollars where we have opportunities. So Margot is the incoming chair of the Hospital Association. What are your thoughts on the process we might go through in order to identify those opportunities and work together with high speed to get those new opportunities submitted into CMS?
Yeah, Kim, I think the benefit on CHA is the multi-member look we have. And so many of us are in different states. And so for me in Banner, I'm a small footprint, but I have access to different states that have looked at different federal models that even with the federal complexity that it is right now in healthcare, there are models that Colorado can pursue. So I think always in partnership with your office and CHA, there are models that people will gain dollars from. It won't be enough, to Rob's point, that will get us through the headwinds that we're facing. And what's going to be provocative, I'll use that word, Donna, and is how do you figure out the right model for Colorado? Because I know there's some out there. We're looking at one. Bring it forward thoughtfully and not get in a food fight, to be candid. We have to be really judicious on where is the biggest need in our state, and all of us can get a little bit, but some of us need more. Us being, like I said, I'm a broken record. Anybody over 70% government payer mix and underserved, we gotta fund those facilities or we won't survive. So I think that's what I meant by being curious, collaborative, transparent, and looking at the greater good. So really using your office, state, and CHA, and let's see what's out there and how can we work together quickly.
Okay, I'm gonna throw the last topic out there, and then we're gonna move into sharing some of the poll results here. So Don, I'll start with you, and then I'm sorry, I want to go back to state-directed payments. So I said Nancy or Shannon or Austin. Any comments that you want to add into how we work better with our hospitals to get through this process as quickly as can, identify opportunities, get them prioritized, and start getting those submissions done and in?
Yeah,
ahead,
thank you,
Austin.
Kim. I can just answer and say, fully agree. We're really interested in collaborating and pursuing, a wide range of opportunities with the SDP program, but others as well, to try to explore how to get and maximize federal funding in our programs. So yeah, just really looking forward to more collaboration there.
Yeah, and invitation to all ideas. You're welcome to submit them to me or to Austin or to Shannon. You're always welcome to reach out. I've asked the Hospital Association to help us pull together. Hospitals often have such wonderful resources and brilliance, especially all across the country, of consultants that are helping. How do we bring together all those minds to help us as we have $378 million on the table at CMS for state-directed payments and another $7.8 million for Denver Health. And so while we're completing that in negotiations with CMS, how do we get the next one underway? So thanks for everybody's collaborative partnership. I just want to touch on undocumented individuals. And there's questions coming through Don, I'll start with you. What are you seeing? The questions are, how do we make sure we're protecting the data through Medicaid, protecting their data through Medicaid? And I just want to be transparent. We're having a hard time protecting at the level that we would want, that are undocumented individuals that are our customers and the residents that we cover. We're having trouble protecting that. And I just want to be transparent. Donna, anything to add? And Dr. Lisa, you're welcome to add if you like. Donna, you're on mute.
Yes, somehow the system put me on mute. I'm very concerned about that and so many other actions that the federal government has taken to potentially prevent us from taking care of people who come to Denver Health. They need medical care. I mean, I think it's tragic what we're seeing. I don't think we can act independent. We need the protection of the state, particularly the Attorney General, in this and so many other areas. The real tragedy is it's also keeping people away from coming. There's a lot of confusion whether it's about law enforcement on the premises, adjacent to the premises, and it's keeping some people away who perhaps might not be undocumented, who are simply afraid of what's going on in the country. So we're providing awareness and training to our employees. We have informed our patients that this is out there as an issue and that we don't really have control over what the federal government is doing at this point.
Thank you. Donna, Lisa, anything to add?
Yeah, I agree completely. Thank you, Dr. Lynn. I think that we're seeing this through for all provider types, right? Outpatient, hospitalization, et cetera. Everyone is struggling with how best to care for the population. We're certainly dealing with people being afraid to access care, and that it has a huge impact because it prevents people from getting the care early that they need and leads to potentially even more expensive uncompensated care later on when they end up in the ER. So lots of hard conversations to have and lots of work that needs to be done in that space.
So I'm going to close now. I want to thank you so much, all of the attendees, our panelists, our speakers, everybody who took time to prep, our coordinators in the back, and most important, all of you who are attending, who are working hard to be in collaborative partnership with each other, with the department, to navigate a really difficult landscape ahead. And takeaway from this meeting is we got a lot of good work to do together, and we will be better, and we're working together, leveraging all the amazing intellect that you heard so much on this call with our 4 rural hospital CEOs, and behind them are 87 plus more that step up every day to do good work in collaboration. So we got a lot of good work to do, but we sure do have a good platform to do it, and that's partnership. So thank you very much, everybody, for joining. Thank you so much for our speakers and panelists. A wonderful week, wonderful day. See ya.